So, welcome everybody. Just sort of hopping right into it and um, having a bit of an idea here of time. I like the group that we have. Small, 12 participants makes it nice and easy to have conversations. Um, what I'm talking about today is, from my perspective, being able to speak to Indigenous methodologies, how they're implemented, and how we interact with within Alberta Health Services. So, specific to my role, I'd like to just talk about some connections we have and that I have with Aim High, a bit of background of who I am, and really getting into the nitty gritty of this presentation, where it's mostly presentations and examples, and then speak about the experiences throughout. So, speaking about Aim High, what I really appreciate, and as Katrina was mentioning, it's really nice to be able to have those connections. I've been with Alberta Health Services for 2 years. I've presented here before, and why I want to bring that up is Katrina was able to do a summer studentship placement with myself and the Population, Public, and Indigenous Health Strategic Clinical Network, and then she transitioned over into this role. The last time I spoke at Aim High, I want to say that was 2 years ago, and made a number of connections both at University of Calgary, but a number of students followed up afterwards and said, "Hey, what's going on? I'm interested in X, Y, and Z." And I just want to acknowledge Sarah was one of those individuals, and now she's been able to. There's been some mentorship discussions, and now she's won an Aim High summer studentship, and she's supporting the diabetes, obesity, and nutrition SCN, implementing a subsidized food prescription program for Indigenous individuals with type 2 diabetes. So it's a long way of saying I like Aim High, welcome and support any individuals on this group or who see the recordings afterwards. And regardless of how this conversation goes or what you take from it, I do want to encourage you guys to reach out, make connections, make supports, because I have seen through these meetings some really good connections and outcomes. I guess just moving into myself for a little bit. My name's Kienan Williams. I'm a First Nation member from Sandy Lake First Nation, and that's in Northern Ontario. The lens that I bring, I'm a northerner. It's a flying community. The nearest town with a road is Sioux Lookout, and that's 200 kilometers away as the crow flies. And I definitely bring with me certainly my Cree perspective and my Cree background and experiences in Ontario. That's interesting because here in Alberta, not only am I a visitor in the territory, I'm constantly learning, I'm constantly evolving, I'm constantly asking what appropriate protocols will be. And I even have a note on my desktop here about the value of deference and humility. Within the health system, from an Alberta Health Services perspective, I'm the Assistant Scientific Director for Indigenous Health, and that's with the Population, Public, and Indigenous Health Strategic Clinical Network. I'm meant to be an academic, I'm meant to be a scientist, I'm meant to, in many ways, and this is a conflict that I can certainly speak to with examples moving forward in this presentation. The expectation of my role is typically to bring Western knowledge, lenses, and approaches, or at the very least to sit in those discussions talking about program implementation or addressing needs. So if patients are having challenges or falling through the gaps, how can we implement and find funding for a patient navigation type model? One of the more interesting, or what I'm finding interesting aspects of this, is that regularly in my role, there are times when I cannot speak to, or someone shares learning with me, and I find challenges because I don't have permission to share that knowledge to the broader context. It might be an oral piece, it might not be my place to say or shared in confidence. And what I'm asking and what we're doing is trying to document those. So not necessarily the number of times something, not necessarily what was not shared, but the number of times I'm placed in a situation where Indigenous knowledge was shared to me that could not perpetuate in the written materials, but could potentially inform the implementation. So that's one very tangible outcome where I'm grappling with the notion of what are the expectations of a provincial health system, as well as how do we respect Indigenous ways of knowing, especially based on my teachings, but also respecting the territory that we're in and the people involved. Really, while I have it as a quick note with the structure of this presentation, I've got half a dozen different projects that I want to present as a bit of an overview, um, and then speak to some of the challenges or the learnings or how are we implementing Indigenous methodologies through this tangible project. And I do want to say the backdrop to all of this is that it's very exciting times with Indigenous health right now within Alberta Health Services. And I would, for those of you that are interested, certainly keep an eye out on announcements in the coming weeks because there will be a few coming. Um, and I'll just leave it at that because, yeah, a little bit of a teaser for everybody. One piece that I wanted to start with, and if you're interested, this is all of these documents are publicly available, with one exception. This is a transformational roadmap for our team. Within Alberta Health Services, I like to say that there are three different pieces to it that are important for Indigenous health or from an Indigenous health perspective. The first is the zones. There's 5 zones in Alberta, North Zone, Edmonton Zone, Central, Calgary, and South. And those are what you typically experience as the frontline service providers. When you go into a clinic or you get a health promoter here in Calgary, those are usually zone type roles. The second piece are the provincial programs. Um, in this case, we've got the Provincial Indigenous Health Program that has staff based in those zones and working hand in hand with the zone programs, but they have a bit of a provincial lens and they're able to connect with the different roles, say a senior advisor, cultural support, and our senior leadership are great examples. The third piece that is important for Indigenous health within AHS is our strategic clinical network, where the PPIH-SCN, and again, some of those changes are about identifying those connection points and strengthening how closely we all work together, because we do. I work very closely from my scientific office, certainly support the provincial health program, as well as supporting or connecting to the zones. So why I want to contextualize that background was really to be able to say what drives our specific department, our PPIH-SCN, and it's this Indigenous Health Transformational Roadmap. It was developed in late 2018. And what I really like about it, and the methodology piece that I want to speak to, is that this was developed in partnership and guided by our Indigenous Health Core Committee. There are 60 some odd members representing all sorts of communities, organizations, regional bodies, and over the course of about a year and a half or so, this overarching transformational roadmap, or for lack of a better word, a strategic plan, is really guiding our work. I highly recommend it. I didn't put it into the slides here. What I like about this document are not only the actions and the tangible the tangible pieces that we're implementing as a team, but the guiding principles. Um, there are 6 of them, and what would be the most interesting, and what I was most impressed by as a provincial health system was the language and the structure that maybe it was a little bit sneaky, but to be able to talk about respecting self-determination, respecting sovereignty and individual communities being able to make their own choices, supporting their communities. And that goes from everything from what the needs are, who to partner with, and articulating how project implementation is moving forward. Um, at the time, um, there was certainly a lot of evidence and a lot of discussion to support putting in guiding principles like this and putting in activities that actually live and breathe those. Um, but there was risk, or there were questions about, are we as a team pushing the envelope within a large health system of over 100,000 employees, to be talking about the provincial perspective or a team's provincial role about sovereignty and jurisdiction? Um, but we were brave. We were humble in our approach, and we certainly had a lot of conversations and a lot of support to implement. So when we got this approved, it turns out the sky did not fall, and we were able to then come back to our communities and the communities that we work with, as well as any number of partners, Indigenous and allies as well, and really be able to say, here's a strong stance that we take, pointing back to the strategic plan that we kind of live and breathe, and then be able to demonstrate how we live those values throughout the projects. Another reference piece that is just nice to have, it's worth a Google. And somebody says we should make this a textbook. Um, Back in 2017, I guess, the AHS Board of Directors asked for a 2-page summary about the state of Indigenous health in Alberta. And this was a large collaboration. We got a lot of people rapidly moving to pull together um, not only resources and historical development of programs, but also sort of Indigenous Health 101, just to make sure that everyone was on the same page, especially at the board of directors level or even just any sort of senior leadership. Um, there are examples or assumptions of different people's understanding of Indigenous health. And ironically, just yesterday, I guess it was, on one of our projects, I had to tell a Zoom call with our team. We're working with some academics down in Australia, and they were asking fundamental questions like, when you guys talk about a reserve, what is a reserve? So before we could get into the importance of things like OCAP, ownership, control, access, and possession, we had to do some level setting and foundational piece. So I found this document to be very helpful, and I share it fairly regularly. Even though it was presented to our CEO and board of directors back in early 2018, the primer really goes into the breakdown. So when we say Indigenous at a provincial lens, Indigenous in my language is Indigenous equals First Nation plus Métis plus Inuit, and then little notes about when we're talking to our federal counterparts with Indigenous Services Canada. But my point is more aptly named when it was the previous group or the previous name of First Nations and Inuit Health Branch. It points out the stark difference of, from a provincial health system, Indigenous includes Métis. From a federal system, Métis are excluded. And the challenges of language of, if we have some people at the table who just assume Métis included when we speak Indigenous, or when we talk to Indigenous Services Canada, those friction points there. As part of my job, very regularly, jurisdictional challenges or barriers are a key piece of it. So I like this primer. It definitely started or is part of a broader conversation that has continued for these last number of years. And interestingly, and that's why I wanted to say the current state, Not only is it a little bit dated because it's over 2 years old now, um, but from a health system perspective, the question becomes, if this is a great resource, what's the process to update it? If before it was developed at the request of board of directors for a time-limited piece, um, with an update, would this remain within the confines of a health system to keep a health system lens on how we as staff and employees are contributing to Indigenous health? Or do we develop a new update process that's more inclusive and a bit more co-designed and get different perspectives, community perspectives, urban perspective, federal perspectives? And then the next natural question is, if that is of interest, then who's responsible? What are the time frames? What are the protocols associated with that? So at this stage right now, this is a bit of a living document. We update it from time to time. But I wanted to speak as an example of, here's a tangible knowledge setting foundational piece and the potential that you can do, use this as a tool moving forward to broach from just sharing knowledge to building relationships as one of many potential opportunities. This is another piece from a health system perspective. As AHS does have guidelines for Indigenous traditional protocols, everything from, or two of the important pieces that I really found interesting with this document. The first is, how do you go about gifting? When is it appropriate? And how do you manage any number of other considerations, such as the Canadian Revenue Agency? So within this protocol, we speak to different scenarios. If it's an individual just coming to speak at a committee meeting or at a broader segment, even something like this, what are the expectations and who do you go, or how do you go about asking what are the protocols in this area? The CRA piece is interesting because technically anything that is provided as during a presentation of that type would be taxable. However, we had to do a bit of a deep dive and say there are exemptions within the CRA code when it's traditional in approach. So we wouldn't want someone to be taxed if we gifted them with tobacco in honor of them. Let's say it's Knowledge Keeper, not just doing the opening and closing, but really speaking to keeping us on track in meetings and providing that that sacred knowledge oversight, for lack of a better term. We would not want to then penalize that individual by providing a T4 at the end of it all saying, according to CRA, we gifted you $50 worth of tobacco. Within the health system, ironically, rules and protocols, I saw this on a meme not too long ago, are developed based on a need and very rarely based out of proactive nature. So certainly this had come up and there is enough uncertainty across departments, divisions, zones where people said, let's spend time developing a protocol guide for this that AHS as an organization can use. To give some very high level of how long this took, I'm aware of some planners who were involved in this work as part of a broader committee, and it took 18 months to draft, roughly, and then another 3 months for approval, and then roughly a month communication time to circulate and distribute within the organization. And I keep it as a resource on my desktop because very regularly, even though it was distributed and is available publicly through the AHS. I believe it's under the Indigenous Health Program. When you're external and internal, we have it listed on our Insight. So you just search Indigenous protocols and this document comes up. One of my learnings has been, and that was part of my personal motivation for coming to a provincial health system, is to learn not only the bureaucracy, but the process for any decision, for any solution being developed in response to a need. And I don't want to focus on the time aspect. What I appreciated with the development of this document in particular was how inclusive it was. So these very fundamental questions of who do we bring in? Who do we have at the table already? Is there an existing table that would be appropriate to bring forward the development of some Indigenous traditional protocols? And if there is, what additional supports could we then bring in? So a protocol in and of itself, while nice and very informative, that becomes static at a certain point, and needs to be updated based on changes and needs that arise. But the value of going through this process and taking that time is that those connection points have been maintained. And I'm not even fully well aware of all the individuals and committees and groups or what have you that had touch points with the development or approval or eyes on. However, those same groups or even just individuals now have a connection for the next time something comes up. And they're like, this is bordering on Indigenous health. I'm not sure what to do. Instead of being apprehensive and being uncertain of what to do, and that sort of fixes, or the fear of that can lead into inaction, they now have an opportunity that they would not otherwise have to reach out, ask questions in a very safe manner. And that can be very scary for people, not just if typically they're non-Indigenous people and this is their this might be a first dipping a toe into Indigenous health or being uncertain there, but then you add the added backdrop of very important social movements that are happening around the world right now. And it is better to be able, in my opinion, it is better to have the conversations than sit in that apprehension and that inactivity. So as exciting as protocol development and policy development can be, this is a really good example from an Indigenous lens of how it can go well and the potential positive impacts it has. I'm going to keep this as a resource on the screen. And from this point sort of forward, I wanted to get into the specific, well, the previous notes were a bit broader organization-wide. From this point forward, it's a bit more project specific, rolling up the sleeves. And these are projects that I have touch points with. So I want to share both publicly available documents and my perspective on key and fascinating pieces. The Four Winds project, its purpose is to develop an Indigenous patient navigation model for South Zone. It's headquartered, and sort of the project staff are headquartered in Lethbridge out of Chinook Regional Hospital. And it is funded through the Prius 4 competition. So that's Partnerships for Research and Health Innovation. I would welcome, for those of you who are interested, please go to the Together for Health website that we have here. That's where we share a bunch of the project updates, where we're at, and as well as calls for surveys and the like. So the other interesting piece, and I won't toss it on the screen here now, but this Vimeo recording and the link that we have here is speaking to one of our big community engagement pieces that we had. And at that session, among all the other planning and pieces and very positive outcomes, we had a graphic recorder who attended, and he put together this video to really show not only his process, but the development of the day. So in terms of Indigenous methodologies in action, this is a great one where we came together, and really the question of the day was, when it comes to patient navigation as an Indigenous person, what are the challenges, what are the strengths and challenges that you experience? And more importantly, let's brainstorm potential solutions in order to address those challenges. Um, Pretty fundamental question. We held it down in Lethbridge. It was a one-day event. And leading up to the activities, what made this engagement session, and it was in the purest sense of the word, very different, was that we actually went back through whatever notes we could find in different AHS departments and teams, and there was a bit of uh, uh, a patient feedback repository that had been put together of historical challenges. So instead of getting together a group of 60 odd people in a room and starting from scratch, we were able to say, here are challenges that we have heard going back to 2016. Um, do these challenges still resonate with you? Have these challenges been addressed? Do you have new challenges that you want to bring forward? And the individuals in the room, a mix of community members, Indigenous service providers outside of AHS, um, some clinicians were part of the discussions, as well as um, representatives from First Nation, Métis, Inuit communities, and some other key points from nearby towns. We had a mayor present and things like that. Very selective to have a very broad and representative cross sample to be able to say, um, here are the challenges that we are aware of, um, but what else is there? And the table groups, it sounds like a very small thing, but it actually was very impactful. Instead of numbering off, we ended up having, I want to say, 6 or 7 different groups. Instead of numbering, saying, we're assigning you to table 1, and we purposely selected those so that we didn't have all the community members or the same family members oftentimes at the same table. We wanted to separate and split out those perspectives. We went back to some of the different animals that were of importance in the Blackfoot Confederacy. And that's what the substance of the graphic recording became. So when we were going throughout the day and doing our group summaries, there would be the Buffalo group, and that's how their identity and that's how they would share would speak to the key summaries and the key challenges that they either experienced or were aware of or were bringing forward to this table. And our graphic recorder, Aaron, spoke to that within um, the image of the bear, and he was able to record in that settings for that group. A very effective intermingling of those groups and the skill sets of the graphic recorder. Now, what I also found, but I was not able to validate, so it's only my opinion, we had a number of elders or knowledge keepers throughout. And I found the different groups, and very intuitively, and again, speaking only from my own teachings, I believe there was a wolf group. So for myself, that's Maigan. And in my community in Northern Ontario, we have certain types of teachings associated with the wolf and the roles and responsibilities. I noticed, and maybe I'm reading into it, these different groups had different themes emerge, and the importance of one, um, I could see, at least from my teachings, a lens or a perspective of what that group did. So a very unintended impact. Um, and I don't know the teachings in this area, um, but also that was one of the more unconscious ways of that was brought forward. Now, in this project, the next piece that we ended up doing, well, two pieces, um, some of the language speakers said, well, if this is a bear, we want to have it bear and Blackfoot. So there was some discussion about, well, what language is Blackfoot representative of all the language groups in the area? Um, and then we got into when we said, well, let's just put it up there and we can certainly add more. We got into a bit of a discussion about old Blackfoot versus new Blackfoot, and it just added to the flavor of the day in a very kind and happy way. Um, what we were able to do, especially with this piece later on in the day, we didn't dwell on challenges for too terribly long, and that was by design because we really wanted to do a bit of a modified Delphi approach of brainstorming solutions, round one, then selecting within each individual group or table what were the most important pieces, what were the priority challenges, and what were the priority solutions that we wanted to bring forward, and then do some small group recording and then say, okay, we have a bit of a laundry list of challenges and solutions as a committee or as the individuals of the room. What might we say are really important and that we as a project can then prioritize with implementation moving forward. Um, those have since become the crux and the focus of our working groups, everything from knowledge resources of navigating services, especially with the federal provincial type divide, but also the gaps and service gaps with different groups. Cultural competency and how we can embed that appropriately or have an ongoing supports within AHS. And that can, as one example, be part of a quarterly meeting that South Zone has with their Indigenous communities and service providers in the area, really maintaining those connections and relationships. Um, Primary healthcare was another one. So you can see how we went from line of sight of not only just what are the challenges, but the groups and the individuals in the room really appreciated that instead of starting from a blank slate, they were able to hear us and say, or we were able to report back and say, we have heard you historically. We are truly doing this as a co-design. Let's build up from what we know, but we also want your voice to be able to replicate in the project implementation moving forward. That graphic recording, it's a massive 30-foot by 8-foot piece of paper, is now hung up in Lethbridge and the Chinook Regional Hospital. And that specific day, which in many regards was a formal project launch, um, resonated so strongly with people that it has set a bit of a new standard about expectations of doing your homework in advance, but also being able to see themselves reflected with the patient navigator that we do have hired now for complex cases and the structure of our governance and committees. Another project that I want to speak to, and these documents they're mostly publicly available, but they're also really new. Echo Plus is enhanced community health outcomes. Um, the plus is just a bit of to distinguish between the project that had started and the current project now. The goal of this project is to provide a hub and spoke model using telemedicine or telehealth to be able to support individuals in their own community with hepatitis C screening and treatment, as well as a broader STBBI, so sexually transmitted and bloodborne infections. Um, that's the overarching project and what we're trying to do. On the left, we're talking about the case reporting form. Every 2 weeks, we, instead of, and so if I am in rural central Alberta, um, and I'm speaking in my case, I'm a First Nation individual, and if there's other questions or worries that I might have hepatitis C or be at risk, or even just want to do that once in a lifetime testing just to make sure, because that's good standard practice, period. Um, uh, Instead of myself having to get transportation to head to either Edmonton or Calgary to see a hepatologist, I can just see my nurse in the community. And the nurse would then be able to, community or local health clinic or doctor, whoever the most responsible person is, they can then complete this case report form and say, we've done the blood work, not identifiable, here's the individual, and that information is presented on a bi-weekly Zoom call with the hepatologist, who can then support the clinician to say, to navigate hepatitis C care and be able to say, yes, this is to confirm it is a positive HCV case, and for this individual, here's how we recommend starting treatment. 12 to 8 to 12 weeks, depending on any number of different other factors, and maintaining and supporting the clinician if they have questions, if there's a maladaptive response, if there's potential for drug interactions, really making sure the individual is supported without them needing to come in to the burden of big urban centers. Especially in the time of COVID, this is very important, and it's definitely part of the move to um, supporting as much as possible distance care, removing the physical distancing type risks, but also making sure that the individual patient is getting appropriate supports, culturally appropriate supports, and responsive care. The second deliverable, the Echo Plus menu, actually came at the request of some of our community partners, because they said it's nice, and I'll admit I'm sometimes I can speak bureaucratic or organizational, and it was very much, what is the thing that we get if we sign up or if we say yes? So at the response, and this is what I appreciate from our team, we pivoted and said, okay, let's make a menu. Let's work together and say, this is what we hear, is this language appropriate? And we use this menu as a tool to build those relationships, but also be accountable and say, you vocalized some confusion or need, and we responded in kind, and here's something that we're able to do very quickly, which is not always an expectation of a health system. And then they also said, well, a menu is great, but um, what specifically happens with a detailed breakdown? What's the level of effort? What's the responsibilities on our staff's part if we join up? And that led to the steps for treatment clause. So really gets into the nitty gritty of saying, from screening to treatment, here's what to do, here's what to expect, to really lower the barrier of, let's say it's a health service provider at the Métis settlements, and they're already enough on their plate. We had one clinician, not from the settlements, but one clinician that we followed up with, that said, why would I go seeking other health inequities when I don't have the capacity or supports to deal with the health inequities that I currently have? Um, that's a scary premise. That's a scary notion, but it's also a statement of truth and reality. So, with our projects, not only are we trying to do these in true co-design and true partnership with our communities that sign on and say, our priority might be, and we're starting with hepatitis C care, but the next community might have an issue with any number of other STBBIs. So let's say HIV, that's something that they want to focus on. Then we work with them and say, in your area, these are the services that are currently available. Are you accessing them? Are you supporting them? Do they make sense for you? Is there any work we can do there? As well, what are the gaps that we can support? And this is where our hub and spoke model really comes into play. And then all those wraparound pieces of, in order to A, take ownership in our project and see yourself reflected, but B, produce tangible pieces that are meaningful at the front lines. As I'm sitting here at my desk in Calgary, what are your needs and how can we respond? And um, these were, most of these, except for the case report form, were unanticipated outcomes or deliverables, outputs from this project. But the we had to, we were supported, but explaining in our monthly project reports to the health system and the funders why the variance, why there was a variance in our project management plan, and a need to develop these tools was then identified and then supported. So we have these pieces of what the communities that we are working with need, what the communities who would be interested, but also have, for any number of different reasons, be it bandwidth, time frame, past challenges with other projects, how can we lower the barriers to include them, as well as reporting in the appropriate checks and balances of a health system. Um, and one of those pieces was, and I'm just going to gloss over this, but being able to speak to patient experiences. And the final patient experience is just being approved by the individuals here. But this is the visual of a self-portrait where they really said, this is who I am. I'm not defined by hepatitis C or anything else that you're talking about. And with that, the undertone that is explicit in the final patient story are the challenges of stigma, are the historical challenges of hepatitis C in particular. 10 years ago was a very difficult drug on your body. It's a lot easier and it's a lot nicer now relative to what it was. And also, more importantly, with the stigma, with residential school, there's any number of different times when someone said, "Oh, I'm not at risk of of hepatitis C because I don't do drugs. I don't inject drugs." Well, there's plenty of examples, especially in the south part of this province, where immunization occurred at residential school, and they used one needle for the entire school. If you're a child, you might be living with hepatitis C, and that could lead to any number of negative outcomes, including cirrhosis of the liver and things like that. Um, so how can we provide our supports now, reduce that stigma, do things in a good way, um, to support people being healthier? And so this was, I just want to circle back and really respect and acknowledge um, the three individuals who have come forward that are brave enough to share their story and to be able to change the narrative, not only within their communities and colleagues, but also to the broader non-Indigenous population. Here's something that I really like, and it's called Radon Reconciliation, my little project that I was working on that could. How this came to be, and specific to the partners, was within Musqueam, so central Alberta, they came forward and said, we want to do work about radon, but we don't want money just to test and potentially identify a problem, but not be able to fix. And previous opportunities said, let's test, but if you identify a home that needs fixed, good luck with that, and that would eventually have to come out of the, in this case, the band budget. So they were looking for funding, and we were able to get $50,000 from Ottawa, from one of the Tri-Council organizations, the Social Services Group, SSRHDC, and really just say we want to not only, social determinants of health include housing. If there's radon, which is a cancerous gas, that is naturally comes out of basements or comes out of the ground, especially in winter in pools and basements, this negatively impacts the health outcomes of individuals. So our proposal was very simple. Let's test in our communities using a very Western approach, and let's also have a budget to be able to fix any homes who have a challenge. And this became, frankly, a huge gamble of, we have this set budget. If we test more homes and the national average is 5% of homes will need to be fixed once tested, what budget would we have if we test 200 homes and 5% of that that we had to fix, and the level of effort being developed there? What if, for any number of different reasons, instead of it being 5% homes that need to be fixed, it's 30% or